running a business and providing the highest quality care. And I think this word cloud from IHI kind of just really resonated with me as I was working on these slides. And so what are we really trying to accomplish today in the time we have together? Really wanting to give that framework on quality improvement. So sort of start with what is it, do a little bit of some historical perspective of where it came from, because I think that really can inform where we go from here and how we think about medical home and the work we do in our office. I certainly want to spend some time integrating and weaving together the work that you all do in medical home and that you have done with us, for many of you that have been with us for a while in our team, in the chapter, and where things are going. And then really think about what's in it for me. So thinking about that as your role, whatever your role is in your practice, and what's involved. So I'm excited about the webinar today and want to thank Iris. As you'll see as we go through this sort of three-part webinar, we'll be together for 2 hours, so please feel free to eat while you're watching. And we have lots of audience participation. So you'll have some videos from Dr. Kressly that you'll see, a video that we did as a medical home practice. I also have some audience polls, kind of the Who Wants to Be a Millionaire kind of interactive piece here. So I really want you guys to be able to ask, we'll have time interspersed throughout this for questions and discussion. So I have some questions sort of built in to get us going. So for this first part of our webinar, where did it come from? Our learning objectives here are really understanding the premise behind what started quality improvement, who are the key players, both locally and nationally, and also looking at some of the organizations that are using QI that some of you may have interfaced with, and I also think that have great websites that some of you may want to engage with during your time in practice and just having as a resource. So I just wanted you to have all of this out there. You'll also note as I kind of launch and get into this that in the screen that you see there, there's some files that I'll reference, some handouts that you can download as part of this. Again, a lot of this is meant to be resources, not trying to do information overload, but what we're really trying to do is get you guys teed up, thinking about this. Hopefully this will be helpful for your work, and again, really want to have you be thinking about the big face-to-face meeting we're having in Harrisburg at the end of November, our Quality Improvement Boot Camp. So as I alluded to earlier, in our work together as the Medical Home Initiative and at the chapter that many of you are engaged in, you've really been doing quality improvement from the beginning. Really the whole idea of engaging in medical home, thinking about practice teams and what we do and registries is quality improvement. It's sort of, just what am I going to do today? What's our quality improvement exercise that we'll be doing? So I think for all of you, you got this. You've already been training for the marathon. You've been hitting the gym, and now it's just refining and continuing that training. So I think that our team and our network and those of you that are engaged in the chapter are really well poised for this work. As you know, you've been engaged with our initiative, some of you since the very beginning. We started actually as a quality improvement initiative with our first grant, which was a 1hr grant back in 2001. And I just put this slide up here to remind us that, as we and Jason and Carol and our team sit down with all of you, we talk about one of our first goals, and this is a slide that, comes from something we talk about all the time, is supporting QI. So we do that through our family-centered care, which I'm going to talk on today, the care coordination and how we collect data, and we've worked with all of you. And, really, again, we all have to remember that ensuring financial viability, whether you're a private solo practitioner, part of a hospital system, or a federal qualified health center, all of us need to be thinking about the bottom line. And you've got to be engaging in quality improvement with the way payment is set up now in order to maintain that viability. So what are some of the things that we've done together just to kind of frame medical home and kind of kick off our discussion today? Our team has implementation guides that most of you have seen around medical home, around transition. One of the first things I know Jason and Carol and Andrea and Iris Ann and Angela talk about right when we come in is you're identifying your practice team. Who is that medical home team? And I just don't think anything gets done in practice, I know in my own practice, without that medical home team in place. Thinking about regular team meetings. You guys do our medical home index. We work on the registries. Many of you are doing patient huddles. We've been working on care planning, developing care planning, care maps. We talk about working with community partners. Many of you have care coordinators in your practice or folks that are designated as such. You're doing integration of care. Our parent advisors at the Medical Home Initiative have been working with you on engaging parent partners, getting feedback. Many of you have done special projects that have required QI. So whether you've gotten J-code certified or NCQA, many of you are involved in our autism work, some of the behavioral health work, and certainly anytime any of us are doing things around billing or office and policy changes, rolling out fluoride varnish, looking at how to bill for the postpartum depression screen, that all requires QI. So I think about that, right, because I think I wanted to sort of really open it up and frame it that way so that as you recognize, this isn't really anything that's going to be totally new to you. It's just giving a new name to many of your old efforts. So I wanted to kind of hone in specifically on quality improvement project initiatives and ask those of you that are on the phone if you could answer this question for us. Where you can see there on the slide, we're asking, has your medical home team worked on quality improvement initiatives or projects? And so yes, you have a QI team member, which I know some of you from being out there in your practices have done. Some of you have talked about it at medical home meetings. Maybe sometimes you've done it if a project comes up, but maybe no, we've talked about it, just haven't had the time, or for some of you it's like, no, not at all, that's why I'm on this webinar. And I'm just going to give folks a few minutes. If you could register your result on that, that would be great. Give people a few minutes to answer. And I know for some of you, that there are folks, I know in our medical home initiative, as you're answering that, I've actually met at some of my practice visits that have said, hey, we're having this person that we have in our office, we're going to have them focus solely on QI and quality incentives. And some folks who have said, we think of quality improvement as something that our care coordinator already does. So I'm hopeful that at least after today we can begin to think a little bit about how you might be doing some of this, or what you might pitch up or have some of your existing team members take on. I don't think we've had everyone participate, but at this point, Iris, I'm thinking we could just broadcast those results just in the interest of time to keep moving. Because can I do that, or are you going to do that? All right. So what we see here from that is we'll be able to see the results of that, the poll. Sorry, hold on. This reminds me of Who Wants to Be a Millionaire. I used to love that show. There we go.
Can you see the results now?
Oh, okay. So can everyone see that, or just me?
No, everyone should be able to see that.
Okay, great. So it seems like for most of us, there's a majority of us that do have some, actually 5 people actually have a QI member. Many have talked about it, and it looks like some are really teeing up. So that's really great. Okay, we can go back to the PowerPoint. It's just helpful to be thinking about that. So we're back in, I think, one of the things that when we think about medical home and what we're doing with QI is really setting that goal, right? So thinking about anything that you want to approach with QI, and I'm going to underscore this a variety of different ways this morning. Really when you're thinking about setting a quality improvement initiative for your practice, really it's understanding what are the guidelines. So for example, I'm going to hone in on and use some examples from real HEDIS measures that I'll talk about in a minute. And so maybe we'll do is we'll talk about that well child visit. That there's a measure that in the first 15 months that one of the HEDIS measures is that kids should be seen 6 times on or before their 15-month birthday. So part of it is going to those guidelines, understanding what they are, following the best practice, so recognizing that you're seeing that child 6 months. What are each of those 6 visits about? Establishing a habit. So maybe it's in your office that you want to have those 6 visits set up, but you have patients that sometimes are coming in set up at 6 visits. Is there a possibility that you can establish a QI initiative that if a child misses their well visit, you can convert a sick or follow-up visit into a well visit so that you can meet that measure? So that has to become habit. And you're just doing continual repetition until it sticks. So kind of thinking about a goal, setting a goal should be something that as a team you come together and discuss, but that's sort of, a premise. And so in thinking about that goal, you really are embracing QI. So QI really is this way that we're changing an aspect of a field that's been identified as needing improvement, right? So that if you were to look at a particular measure that you're doing in your office and you find, hey, 90% of our 15-month-olds are meeting that measure, that might not be the one that you're going to pick. You're going to pick something that might need improvement. I know, for example, in our office, we had a VFC issue in a visit, I shouldn't say an issue, we had an audit, and we found that our HPV vaccine rates were so low, and that really became one of our goals and became a quality improvement initiative. So, you know, you really want to identify things that actually do need improvement and that you can make an impact on. So you want to look at the function of your system and then maybe changing that system. Maybe you're changing your office flow, maybe you're changing your electronic health record. But the biggest thing with quality improvement is that you're focusing on our patients, our children, and in many cases in pediatrics, our families, and you're also looking at your team. So it's the parents and their ability to get their children in or the youth, but also your medical home team and the flow, and then using your data, whether it's data you get from the insurance company or data that you have to actually move things forward. So we know that quality improvement in healthcare really is, you know, looking at that association between improving the healthcare services and the desired healthcare outcomes. So that, you know, improving getting children their HPV vaccine and the desired healthcare outcomes that you have more kids vaccinated and hopefully a lower incidence of cervical cancer, to use that as an example. And we should all know there's always room for improvement, right? That's what I say to my own kids all the time. You're never hit a ceiling. And I think with quality improvement, even if you move the needle, even when we moved our HPV vaccines rates up, even if we approached 99%, which we didn't, the key is there's always room to improve because many times you're trying to maintain those efforts. And you can't improve what you don't know. And that's what Dr. Kressly would talk about as well. That's why measurement is key. I can't tell you, and I think all of you that are part of Medical Home have experienced this, where, you know, looking at your registry or a project you're involved with us, when we pull that data and you look at it, oftentimes we underestimate what we're doing, or we overestimate. We say, oh, you know, of course, you know, if I had, you know, were to bet in Atlantic City, I would have thought, you know, 75% of my teens had been vaccinated against HPV. And we were woefully below 50% when my practice looked at it. So sometimes, you know, that data, there's power in data. It can be motivating, it can be encouraging too, because you can also see the progress you've made, and as a team you can see that you've made some strides. So, you know, we wanted to give you guys some data. And, you know, there was a study long ago that's sort of studying QI on the mark that showed that only just over half of patients in the United States were getting recommended care. And that's part of the Institute of Medicine that I'll talk a little bit more about, really started, you know, it fueled a fire for them to start looking at and documenting quality and safety and putting out a lot of the materials that, you know, you may have read, you know, causing the quality chasm that's out there. There's lots of things that the Institute of Medicine that comes from our federal government kind of puts out as sort of the beacons for us to follow. I thought this was really interesting, and I included this slide. I don't know how many of you have heard of Atul Gawande. He writes some really interesting books. I haven't gotten through all of them, but he's a really interesting read as a physician. And one of his books is a checklist manifesto that just comes from how to get things right. And I always think we can learn from other industries because they're applicable to healthcare in some arenas. And so one of the things that he talks about in this book that I recommend for those of you that are interested is about QI success in other industries. So he tells a story about how in the Army they held a competition in the mid-30s for looking for people to contract with them for a long-range bomber plane. And the Boeing plane that was the favorite crashed during the competition, and it was thought to be due to pilot error because the new plane was much more complex than a standard plane, and it was deemed too much airplane for one man to fly. It had so many, you know, gadgets that, you know, it just didn't work, and even though it was deemed to be sort of the most, you know, souped-up airplane. So the engineers then gave the contract to another airline, but they trialed a few of the Boeing planes. With the implementation, they had a checklist, and they used that checklist for takeoff, and they simplified this plane's complexity. And by just rolling out this checklist and sort of standardizing the process, not a single crash occurred later over 1.8 million miles flown. So they made a large-scale purchase of the plane, and they dubbed it, which was ultimately what many of us know as the B-19 if you follow airplanes. But I think that there's a lesson in here, sort of looking at, you know, here's Boeing, here's this, you know, the shizzle of the airplane industry, a failure, and people then looked at, you know, really did what we call a root cause analysis, what was possibly happening. And, you know, when you read the book, it talks a little bit about could something almost be too improved. But drilling down to the basics, something like a checklist, standardizing the flow, these are things that we can easily do in our office to engage in quality improvement. So I felt like that was a good example to kind of think about. So, you know, one of the things that Dr. Kressly is going to talk about in her video in a minute are the players. So we just wanted you to have these and sort of just highlight them. Many of you are familiar with NCQA, which is the National Committee on Quality Assurance. that some people have chosen to get NC-TRACE certified. They're not-for-profit. Their goal is improving healthcare quality. When you can look at your performance and the plans, can look. It's interesting. I think NC-TRACE several years ago was really the beacon. Lots of plans were on board for recognizing NC-TRACE recognition. Fewer and fewer plans right now are paying, at least in my neck of the woods, and I've been hearing less in Pennsylvania. It doesn't mean we shouldn't do it. My practice did it. I think there's value in, again, the structure, but just to know that they're a player out there. They hold webinars and things that you can engage in. I'm going to talk more about other players, but the Institute of Medicine that I alluded to is, I just wanted to, this is one of the landmark reports, the Crossing the Quality Chasm. And that gap was defined by them. And really the goal, and again, what promulgated the quality improvement world was they looked at, what was thought to be scientifically sound, and then what was actually thought to be possible in the actual practice, right? Because many of us know, we might think about things or we have an idea, but then, you think about, am I really going to be able to roll that out of my office? Are we really going to be able to do the screener knowing that we have this volume of kids in our waiting room or whatever it may be? And so that really is, where a lot is talked about in that report. And what sort of came out of that was this idea of, healthcare quality improvement efforts to kind of look at where the gaps are and how we address them. So from that, they had these what they called quality aims that I wanted to sort of highlight each one of those. And I think they're worth kind of just knowing that they're in there, again, just to frame our discussion so that you all know and think about why we are doing what we're doing and we're talking about this. So the idea of safe, that the quality, so we should be practicing safe care. And so that's, so that patients avoid injury to patients from the care that's intended to help them, right? All the care that we give patients should be safe. Care should be effective. So we want to think about overuse of ineffective care and underuse of effective care, right? So we want to make sure that we're, we know that fluoride varnish helps in practice. We want to make sure that we're maximizing that. But we also want to make sure that, like in the adult industry, we're not inappropriately giving, vaccines to increase blood counts that aren't needed. Things should be patient and family-centered. They say patient-centered, but I think a lot of us have been able to get family in there. I think in pediatrics we have to have the P and the F, right? So things should, our care should be respectful and responsive to the individual patients, their preferences, their cultural needs, and their values. It's great that that's a quality aim, and also timely. We want to reduce waits. We want to get patients in when they need to be seen. We want to avoid harmful delays for those who are receiving and giving care. We want things to be efficient. So, we want to think about efficiency in terms of supplies, equipment that we're using hands-on in our office, but also ideas and energy. You don't want to be, spending your time creating or, think about, I know years ago, it was many years ago, there was a rotavirus vaccine before the one we currently have that was quickly pulled off the market for causing a lot of insusception. And so a lot of folks who had rolled out quality improvement initiatives, had spent all this time for a vaccine that was deemed not to be appropriate or effective. So we wanted to make sure that we're rolling out things that are evidence-based and effective. And we want to make sure that our care does not vary in quality. And so that patients should be receiving the same care, whether, due to gender, sexual orientation, their race, ethnicity, insurance status, regardless of where they're located, their distance from tertiary care center. So it should never affect your care whether you only have Medicaid, private insurance, or both. So that's really, the Institute of Medicine came out with those quality aims, and it very much drives a lot of what we do. A lot of other players got on board. So the Institute for Healthcare Improvement has an awesome website. They have lots of toolkits. There's great things for you if you want to. They actually have great conferences. They're just very, very expensive to attend. But they really have done a lot of great things in terms of collaboration. They really have some very innovative healthcare quality ideas and reform. And I love their conferences because they have pieces that are, it's well beyond the physician, which we know quality improvement is well beyond the physician. They really tailor lots of their things to nurses, office managers, administrative staff, and recognize the team approach to healthcare. Another important player is the Agency for Healthcare Research and Quality. They're one of the federal agencies that, their mission is improving the safety and quality of our healthcare system. So they actually have some great, some great resources. In fact, one of the things that IRIS, I think, has as part of our toolkit is that there's a HRSA quality improvement tools and resources there as one of your tools there, one of the files. So, they are definitely a player. They have a toolbox that actually has lots of toolkits in it that's worth taking a look at in terms of quality improvement. So I wanted to make sure you're aware of that. That's HRSA that I mentioned. This is the federal agency. And then Dr. Kressly in her video is going to talk a little bit about meaningful use. And so meaningful use and using many of us are in, I think probably in our different phases of hitting meaningful use certification. But really part of that, and what she'll talk about in her video in a minute, is that we're using our electronic health records to improve that quality, safety, and efficiency. So, really meaningful use is hopefully helping us improve our population health management, improving better outcomes for patients. So by achieving and working on meaningful use, we're addressing quality improvement. One of the other things that I wanted to highlight is sort of, going through some definitions before we launched into the first video, is that I thought it was useful, we use the word P for P, or pay for performance, and I wanted to make sure in this webinar that, again, level the playing field. How many of us really know, where did pay for performance come from, and what really is it? So as part of that report I alluded to earlier with the Institute of Medicine and those quality aims, as part of their recommendations that came out of that, the federal government really was charged with, looking at payment options that closely aligned with what we were trying to do in quality improvement. And, if we're asking, physicians and practices to do more, how can we align those incentives with what needs to change? So that's where P for P sort of came from. So the idea and sort of the thinking was that fee-for-service encouraged this overuse, that people would be bringing people in more, and that capitation encouraged underuse, that you just got an amount every month. And so that P for P, sort of the thought was that it created the right incentive. It was kind of a hybrid or a middle ground between those two ways of payment. So it really came out as an overall quality and sort of cost management strategy from those recommendations. And it really, using pay for performance, it describes those initiatives that really is meant to improve, the quality and efficiency. So it's these financial incentives to those of us in practice or hospitals or systems that's meant to improve the quality outcomes. So, you might get P for P dollars if you improve your asthma care and children are on, inhalers and they're getting their flu shots. So in healthcare reform, there's an expansion of pay for performance in Medicare and with hospital-based purchasing and bonus plans, which is far beyond the scope of what I wanted to talk about today, but I certainly wanted to make sure you guys were aware of it. So how does it, incentivize, or I'm going to talk about it in a bit at the triple aim, really this better, better cost, better management for the populations. What the federal government really sort of embedded a lot of P for P already in our community health centers and federal qualified health centers. So in order to maintain that status, they have quality assurance programs. So the pay for performance is kind of embedded in there. And as part of that, a lot of the goals that came out of the federal government, they stated our Centers for Medicare and Medicaid, which really drives a lot of this for us, stated that, by 2018, the majority of our fee-for-service payment was linked to quality or value. So it's just, again, important. We've got to get our hands around this, because we're, if we're not engaged in quality and pay for performance, we're going to be left by the curb and not be able to, succeed in primary care, pediatric care. We're not, specialists that are able to do procedures. We're in the business of improving health care for children. So we have to be, be on the bus. And just to give you some historical time frames, in 2012, there were almost no payments made to these alternative payment models. And now we're talking about, like, 6 years later, this is going to be really the driving force. So that's for a lot of us that have been in practice for a while. We've got to get our hands around what this is, because it's definitely, a change in how we're paid. So I wanted you to have, a slide kind of looking at the forms of pay for performance. So, there's bonuses. It really depends on your contracts with your payers, but just if you hear some of these phrases, so you might get minimum targets for something, so you'll get a bonus. And then there's withhold. So there'll be a percentage. You might get paid for something, but a portion of your reimbursement you don't get until you actually meet that requirement. Some of the payers have quality grants, so they might have like a specific payment for quality improvement projects. So some of you that were involved in the Governor's Chronic Care Commission, that might have been, some of those, there are some quality grants there. Some of the payers pay for staff. And then there's different, reimbursement for various initiatives. So chronic care, so people might have had, treatment plans or asthma action plans with patients with asthma. And there's different initiatives that come out, but there's, they may be very specific. And then there have been some payers that did some shared savings plans. I know that a while ago, Highmark was engaged in some of that out in the West. So the idea is that if you're able to manage costs and the payer saves money, they give some of that shared savings back to you at the end of the year when you can demonstrate that you saved that. So those are the different forms. How does it affect you in practice? So again, you might get these direct incentive payments for improved quality, and they compare you, they establish these benchmarks. So, it's you out in, John Smith Pediatrics, but they're looking at your peers that are within your other practices that are like yours, other pediatricians. And as I said, you might get those bonus payments. For some practices, you might get a higher per member per month payment. So if you get paid that way, sometimes you might get higher fee schedules. So they might, use a different fee schedule if you hit that. So, one of the things Dr. Kressly is going to touch on too, that one of the other big things coming down the pike with this is that sometimes you might get, there might be preferential networks by some payers, so that they look at their, their practices, and if they have poor performers, as it relates to pay for performance, they may, put you in a different network. And there's also this idea that there's preferential co-pays by some payers to incentivize patients to seek care at higher quality practices. So the idea being that, they might say to certain, patients, well, if you go to John Smith's Pediatrics, you only have to pay a $20 copay because their quality scores are so high. You're free to go to Susie Jones' practice, but because her quality scores are lower, you're going to have to pay $50 as a copay, which, as you can imagine, for a lot of our families would be a complete disincentive. As much as they might be bonded to one of us, they have multiple children, if they're going to have to pay higher copays, they're going to seek the practice with the lower pay, especially if it's right in their neighborhood. So these, again, all the reasons for you to be thinking about how you can maximize your quality score. These are some of the things that are coming down the pike. So you want to think about the quality measures versus quality improvement. So the quality metrics are the key to the measurement portion of the quality improvement. What you're measuring and seeing where you fall out. What percentage of your children have had a dental visit in the last year. That's the measurement part. It's a small part. But really to actually improve that, to say, okay, we want to improve how many of our patients had a dental visit, that's really where we have to think about it, a systems level mindset. And that really gets back to a lot of what you've done in medical home. You want to be committed to this. What are we going to do in our practice? Who needs to be part of the team? How can we roll out an initiative that's going to help us improve this dental, compliance with your dental visits? So it's important to kind of have that distinction. The metrics and the measurements inform the improvement that you're going to do. But the quality improvement overlay, that whole umbrella, is really what we're about. And so these measures that we're looking at, and things we'll talk about a little bit more, where did they come from? You might say, you kind of get this list in front of you from a payer and say, how did they choose these? Well, for us in pediatrics, there's definitely, luckily a lot of them come from the evidence base. So things like Bright Futures or clinical practice guidelines, knowing that, vaccines are supposed to be given at certain times. There's also stakeholder groups that build consensus, so thinking about, a lot of things that have come down now recently. Bright Futures is recommending postpartum depression screening and fluoride varnish. So there's lots of nonprofits and different agencies, but you can actually, in your slides there's actually an overview of the quality measures that you can take a look at if you're really interested in knowing the derivative of where they came from. So before we launch into the discussion, I wanted to just briefly show Dr. Kressly's video that underscores a lot of what I talked about here. So we're going to launch into.
Hello and welcome. My name is Sue Kressly, and I'm a practicing pediatrician in Warrington, PA, and the immediate past president of the Pennsylvania chapter of the AAP. In addition, I serve on several national AAP councils, committees, and sections, including the Council on Quality Improvement and Patient Safety, the Section on Administration and Practice Management, the Council on Clinical Information Technology, and others. It's my pleasure to speak with you today. Welcome to this three-part series on quality improvement presented on behalf of the PA chapter of the American Academy of Pediatrics and the Pennsylvania Medical Home Initiative. The PA Medical Home Initiative is a project of the PA Department of Health in partnership with the Pennsylvania chapter of the American Academy of Pediatrics. This is meant to be an introduction and provide you with background information so you can effectively embark on quality improvement in your practice. Part 1 in our series will look at quality improvement, what that really means, and where it started. Our learning objectives for this first segment are to understand the premise behind quality improvement, identify the key players that have QI as a core mission, and recognize other organizations that use QI and quality measurement. As physicians, practice managers, clinical and support staff, and other team members, we are all dedicated to improving the health of our patients. Quality in healthcare really is the link between improving what we do and how it improves the health outcomes of our patients that we see and the whole population that we serve. Our work is never done. We know there's always room for improvement, and even when we're rock stars, it takes work to remain at the peak of our game. The underlying premise of this work is that we can't improve what we don't know about, and we need to have some way of measuring both our baseline performance and whether the changes we make have true improvements in outcomes. This is just one of the studies that have demonstrated that we have significant gaps in what the evidence shows is good care and what our patients actually receive. Research studies and reports from the Institute of Medicine provide focus and urgency to our work of improving quality and safety for our patients. So who are the players in the quality space? Most of you have heard about NCQA, the National Center for Quality Assurance, but not everyone knows who they are or what they do. NCQA is a private, nonprofit organization that's been around for over 25 years. Their mission statement reports that they are dedicated to improving healthcare quality. They do this through a variety of programs for many different stakeholders, from insurance payer plans to practices like ours. Insurance companies report HEDIS metrics to NCQA, so the public can compare performance when choosing a plan, and payers can compare their performance to others and work to improve. You may or may not have heard of the Institute for Healthcare Improvement, or IHI. This is an independent nonprofit organization founded around the same time as NCQA, but has an international focus and really looks at how we can collaborate, work together across different healthcare systems to accelerate improvement and healthcare reform. The government has a big stake in quality. If you think about it, government, that's really our tax dollars, fund Medicare and Medicaid, which covers more than a third of all Americans. The Agency for Healthcare Research and Quality, or AHRQ, is the lead federal agency charged with improving the safety and quality of America's healthcare. HRSA, the Health Resources and Services Administration, is part of the Health and Human Services, or HHS. It's the primary federal agency for improving healthcare to our most vulnerable people. So where else is QI used? It may be easier to speak about the places in healthcare that are not involved in QI at this point. Clearly part of the entire healthcare IT movement through the Affordable Care Act that led to Meaningful Use program is founded on the premise of improving healthcare. As we move toward pay for value in MIPS and alternative payment models, Medicare is all about paying for quality. In the meantime, many of our private payers use pay-for-performance programs to drive quality improvement. Practice transformation around the medical home model, whether or not you choose to be recognized by the Joint Commission or NCQA, has measuring and improving quality at its core. Board Maintenance of Certification, or MOC, has an entire section developed to fostering, measuring, and evaluating quality in its Part 4 Improvement in Practice program. The Meaningful Use, or MU program, was designed to promote adoption of and improvement in use of electronic health records. All of this was done to improve quality, safety, and efficiency, as well as to reduce healthcare disparities, and ultimately was designed to move toward better clinical and population health outcomes. One could argue what the true costs and outcomes have been to the MU program and whether the return on investment has been demonstrated. But it's clear we are not going back to paper, and the move to improve quality using data is here to stay. Many practices across the state have at least one payer that offers a pay-for-performance program. High-quality performers can be rewarded in a variety of ways, but almost always result in real additional monies to the practice. This may come in the form of bonus payments. For my practice, our major payer will be rewarding us for our high-quality work with a bonus payment that covers more than one nurse's salary and benefits for the year. In addition, we got additional monies throughout the year as part of our monthly capitation checks. Some payers are intentionally narrowing their networks and terminating practices with low quality performance. We haven't seen that as much in PA as in other parts of the country. But if your quality is not as good as your peers and there is network adequacy in your region, your patients may be forced to leave you for a higher performing practice. In some areas of Pennsylvania, there are payers who are giving patients lower copays to go to high-performing practices. I've seen patients transfer to my practice because their out-of-pocket expenses are lower in our high-performing practice. We will talk more about how to measure quality and collect data in the form of quality metrics, but to actually improve your quality takes more than collecting numerators and denominators. It takes a mindset of your entire practice, from leadership to every team member. There must be a mindset of, how could we be doing this better, from all dimensions of your practice. Quality improvement also requires commitment to the process. That means time to do the hard work involved and an understanding of why this matters. So where do those quality measures we alluded to in the previous slide come from? In general, they start from evidence-based research and are based on clinical practice guidelines. In most cases, there is a stakeholder group convened to build consensus. Those stakeholders almost always include practicing physicians, and many of the pediatric guidelines have included AAP members just like you. I've been asked to provide input into various quality measures over the past few years. The outcome does not always reflect my best guidance, but there is general consensus achieved by the stakeholders around the table. Quality measures can be developed by government agencies, private nonprofits, for-profits, and others. Some of our biggest struggles as pediatricians is that these measures are often adapted in some way by payers or health systems, and it seems like everyone wants their own customization of a national quality measure. While there is work being done at the AAP and in other organizations to harmonize and agree upon definitions of measures for children, this is ongoing work and will continue to require our willingness to be part of the process and not just complain about the outcome. In addition, sometimes the measures get used outside their original intent and have unintended consequences. For example, the chlamydia screening in women was originally intended to begin to measure the burden of chlamydia on at-risk adolescents in the Medicaid population. Unfortunately, there's no good way from claims data to define an at-risk woman, and suboptimal surrogates on birth control having had a pregnancy test were used. Additionally, in the Medicaid population, there is no risk of disclosure for parents getting an EOB. As this was widened to private payers, it began to have wider implications. So hopefully by now you're getting the picture that if you're not already involved in or getting geared up for quality improvement in your practice, you're at risk to have the healthcare system pass you by as you stand at the curb and watch the bus drive away. This concludes the first in the three-part series on quality improvement. We hope you have a good understanding of the forces behind quality improvement and recognize the organizations which develop, measure, report, and promote quality measurement and quality improvement. We encourage you to contemplate and discuss further as time allows.
Great, thank you. And thanks, Dr. Kressly, virtually. So what I thought we would do before, to sort of wrap up our first leg of this webinar was just open it up for some discussion. Is there anyone that we didn't really talk about in the quality space that you get that you think is a player that we didn't mention? And any of you wanting to share anything about the quality report cards you receive from any of the payers, or do you have meetings with your payers to talk about your quality?
If anyone that's on the phone that would like to give feedback, it's #6 to unmute your line. Is there someone there? You're also welcome to type in the Q&A box. Again, for the folks that are on the phone, hit #6 to unmute your line to ask any questions or give feedback.
So I'll highlight some of the other questions our week, so folks just chime in if any of these things are resonating. So the idea for discussion and the idea for sort of like, what do we want you to be thinking about to get yourselves keyed up and prepped, and what we want to think about for our November meeting. Do you actually have a QI team in your office? who is on the QI team, what is their role, is there a way to kind of, maybe expand or have sort of almost like a subcommittee, if you will, of your medical home team that includes some people focused on QI and dedicate some of their, their role, because a lot of this overlaps. A lot of what we're going to talk about, you'll see, integrates into care coordination. So thinking about as a team, when could you do this? Is there an opportunity, if there's someone in your office, an office manager, a biller who gets those report cards that Dr. Kressly alluded to, maybe that's kind of like the tickler to get your guys to be thinking, all right, we got this report card at our next staff meeting, we'll address this, we'll review the numbers, and then maybe our subcommittee will meet once a month to roll out an action plan. So really begin to think about, QI and your efforts and your pay for performance as, if you haven't already, as sort of a very distinct agenda item, a very distinct meeting. And think about, what Dr. Kressly talked about with her practice, that there was someone in her neighborhood, she had a patient who came to her because of her quality scores. And this is where we're really trying to be proactive here, even with this webinar, thinking about is your practice potentially at risk due to suboptimal quality, being carved out in, losing patients because of performance measures. It could be really well known, but this kind of effort is going to be driven by the payers. So you want to be thinking about that and thinking about your quality scores and looking at them. And think about, I think there's some folks out in the West that have done JCO certification in the UPMC network. I think some folks have been NCQA certified. So thinking about whether you're planning on renewing, a lot of these cost money. We've seen less and less practices in the chapter that are getting certified because of, if the payers aren't recognizing it and you can do a lot of the quality improvement, you can still go through a lot of those exercises and know that a lot of the work that you do with us in medical home crosswalks with those certifications. So if you're not going to necessarily get paid by a payer for that specific certification and have to pay the thousands of dollars to do it, you might still want to think about QI as it relates to some of the initiatives, ways that you can link it to P4P, ways that you can link it to the work that you do with us in medical home, that we can help you still get that payment but not necessarily have to pay for the specific certification. I know one of our big blues out here, our equivalent of Blue Cross out in southeastern PA, equivalent to like Highmark, I guess, for those of you out in the central or western parts of the Commonwealth, used to pay for NCQA certification depending on the level. Now NCQA is switching that to like one certification being on or off, but it used to be level 1, 2, and 3, and it used to be that you got a certain dollar per member per month based on your level of certification. So if you had a higher level, you got more money per member per month. So there was definitely an incentive, and that was on top of your payment. The Independence Blue Cross has now stopped paying for that. So it's not to say, again, it's all for naught, because I think a lot of folks who just get certified, there's a lot of infrastructure that comes from it. But, really looking at your payers and really getting a handle on who are your big payers, what are your insurance companies, so who are the big payers that are paying you, and what are their quality incentives, and, what's in it for you and what's worth it. Any comments or questions before I move on to the second part?
I don't see anything on the Q&A, and no one's unmuted yet.
Okay.
So
we're going to keep going. I hope people are enjoying their lunches. So, in the second part, we wanted to talk a little bit about what's in it for me. We touched briefly, as our first part, we really tried to give you some infrastructure, some scaffolding on where this comes from. I think it's helpful to understand a little bit of the history, and, I think rather than just sort of saying, what actually do we mean when we say QI, because I think it's used a whole lot. But now really thinking about what's in it for me. So kind of really getting the teams and those of you on the phone to maybe bring back to your, your groups in practice, because sometimes as a medical director, as an office manager, as a care coordinator, you have to sometimes be the cheerleader to get people jazzed about this, to say, these are the reasons you want to get involved in QI, and really begin to understand what's your return on investment. That's what ROI is, return on investment for participating, and really start to think about what the QI can bring to your practice through your participation in this. So we talked briefly about this, but it's important because you're thinking about the quality, the safety, the efficiency of care that you're delivering. You're certainly, hopefully going to be improving the patient and family-centered care, and ultimately the satisfaction of the parents and the patients that are receiving care. Often with QI, you're working collaboratively with quality and safety officers, whether that's in your hospital or your network. You're working collaboratively with your insurance companies. sitting down with them regularly, which I think is really important. You're working with your practice team. You know, sometimes these initiatives, it's like, you know, doing a project together brings people together. There's nothing more bonding than NCQA meetings, right? And other health system leaders. So you're working collaboratively. Often it helps you understand the perspective of sometimes what some of your staff and team members do. You're also learning and practicing the evidence-based guidelines. You're improving your quality scores and hopefully increasing your payment, because if the scores go up for a lot of the payers, your payment will go up. Lots of times you can share or publish, you know, present your results to help others. So, hey, here's what we did in my practice to improve, you know, our HPV rates. And so that's always really helpful. And certainly Dr. Kressly is going to talk a little bit about in her next video the maintenance of certification part 4. So for the physicians in your practice, a lot of times the quality improvement projects that you can pick, I always say pick something that's meaningful, that's actually going to, you know, make a difference in your practice, not just some exercise to get the points. You want to actually do something that can improve care. So we said this before, but you really can't improve what you don't measure. You know, so you really need to establish a floor when you're doing these things. Pull your data, pull your numbers, see where you are and where you want to go. You want to focus on the patient. We always say in our practice, you know, if you keep the eye and your focus and your goal is the patient and the family that walk through that door, you can't go wrong. So the care provision is evidence-based. We all want to provide evidence-based care to our patients and pediatrics. We want to, you know, implore patient safety. We want to make sure that we've got parents engaged and patients engaged when they're youth or they're of age to be engaged. That's critical because, you know, you might embark on some quality improvement effort. I know Katie, who's in my office, we wanted to sort of establish these asthma visits, and we were going to start bringing in patients just to do like asthma checks. And we got feedback from our parents that parents didn't really want to come in just for asthma. They wanted it to be linked to another visit or another, you know, initiative, or they were, you know, they might be coming to our hospital for another appointment. And so again, with all the best of intentions, you know, it was so critical for us to hear that from our families before we embarked on some huge QI project. So I can't underscore enough the importance from hearing from your families. You want to coordinate care with other parts of this healthcare system for sure, and see what other folks are doing. So you might be, you know, maybe within your same healthcare system, or you have multiple office sites. You know, if you're a private practice that has multiple sites, roll out a QI initiative that you all can do together among multiple practices. You might be able to have someone go to a different office so that you're not duplicating efforts, or have one office launch one office launch another, and then you share results and figure out what works. Cultural competence and really thinking about the health literacy of our patients, thinking about patient-centered communication, linguistically appropriate care, honoring the values and cultures, thinking about, you know, we've been having a lot of discussion about postpartum depression screening and whether, you know, I'm a big fan of actually doing it on paper, even though it's paper, because I just feel like families answer more candidly than when I ask them the questions myself in the EHR. We have it built into our EHR. So while it's double work, to me it honors the culture and the values and the traditions, and then we address literacy issues. But it's about knowing your patient population and piloting and hearing those things. So, you know, I think I can't, as I mentioned, underscore enough the role of family-centered care. And I think our parent partners and our family advisors, parent advisors that come out and work with you as part of Medical Home, hopefully many of you have gotten to meet them, and they have been key partners in this. And so thinking about quality improvement and thinking about some of what many of you have done. So some of the resource nights that you've had with the parent partners, maybe you can invite parent partners to your staff meetings. I know in my practice we had our parent partner help us with some of our NCQA work that we did, and you know, runs our educational sessions. I know some of the practices have done focus groups, so it's a great opportunity with your group of parents to say, hey, we're looking to roll out this QI initiative. We're going to be having dental hygienists in our office. You know, what do you think about that? What do you think about where you might want to receive dental care? And that in of itself would be, you know, a way to improve your dental, you know, your rates of dental visits. And certainly I hope all of you know who your parent and family advisor is. Work with your parent partners. So part of that, and part of quality improvement, and part of what the payers use, are getting feedback. You know, in any industry, right? Like how many times are you think about the retail industry, or you get your car inspected. I feel like I get stalked from the Subaru dealer all the time asking my input on what my experience was like. So most industries use consumer feedback for experiential quality improvement. And we're no different in healthcare. And many of our insurance companies are actually surveying your patients and your families that come to your offices. So even if you haven't gotten that data, many of them are doing it. You may or may not know it. And those things can influence your quality scores. As you guys know, as part of Medical Home, we have our Medical Home Family Surveys that we give out that we help support you with. And we're working right now actually actively on getting practice reports out to you guys, so you should have those soon. I mentioned the payer surveys. Some of you are getting suggestion boxes in your offices. And, I think for some folks, whether you're doing NCQA or otherwise, there are definitely some, third-party groups that you can hire or pay, because I think it's hard for many of us to engage and, sometimes if you don't have Medical Home, or you might not have the manpower in your office to conduct your own surveys. So there are, I think NRC Connect is one of the ones that we've used in my health system, but you can engage or pay to have other folks, if you need that for NCQA or just in general, to have that done in your office. But the feedback from your families is instrumental in informing what we can do and how we can improve. So I just wanted to have a slide here so that you all could see, what our parent advisors will sometimes do when they come out to the office to get the conversation going with some of the parents. They'll run focus groups to help you run focus groups, just to get parents talking about what their experience has been with their child, what it has been helpful or challenging in the practice. Is there any unmet needs? Giving recommendations. So we really try to have and help foster an innocuous discussion with parents in your practice, with your parent partners, to help you improve. It's really been quite helpful. So I just wanted to take a quick audience poll here to ask folks how often you're reviewing your quality report cards from payers. So for those of you that have them, it'd be great to talk a little bit about that. Hopefully most of you are getting them. So as we're seeing here, we're asking you, do you regularly have meetings? Do you sometimes, when they come in, is that kind of your impetus for doing it? You do it once in a while. We wish we did, but we don't, or we never do. So it looks like some folks have meetings. And this, this is, again, we just wanted to highlight this in this discussion, because this is in some ways, and I will say this without being disparaging in any way, you want to, when you take a look at those report cards, that is the payer data, but you want to have a dialogue with your insurance company. We certainly have had situations where sometimes their data is not correct. Like we had a glitch in our system once with vaccines getting put there. They weren't seeing something from the VFC, so we were getting dinged. There were vaccines that they were saying we didn't give that we did, and that was informing our quality scores. Take a look at those report cards and discuss them and figure out if some things don't make sense. Question the data. Have a very collaborative relationship with your payers. And maybe think about, even if one of the things you could get from this webinar is, what am I going to do in my office next Tuesday? If maybe, schedule some regular time, devote 15 minutes of meetings that you have with your Medical Home team to review those quality report cards. Because I think you'll find that, you might just pick one or two things that you can, again, baby steps. One, what you look at, wow, I know we could do better. Hey, I know we're doing this. We just must not be capturing it the right way. So sometimes it's about reporting. We have talked at our here at my practice about the dental visits, because we have like these mobile vans that go out to schools, which is great, because at the end of the day, right, what we want is we want these kids to get oral health care. So we were partnering with them on ways that they could capture that, because we were getting dinged when these kids were getting their dental visits at their high schools, which we want to do. We want them to get their care, but we were trying to work with them on ways to capture that so that it didn't look like we weren't actually, these kids weren't getting their dental care. So things like that. Begin to think about some of those things. I don't think a lot of you are already thinking about it, and some of you hopefully will after this webinar. I think we can flip back to the presentation, Iris. Thank you. So the one thing that we wanted to focus on now is kind of thinking about improved payments. So, I do think that providing the evidence-based services adds additional revenue. So things like, are you, fluoride varnish, for example, to me is one that comes to mind, right? So, it's included in Bright Futures. They apply fluoride varnish up to 4 times a year, up until child's 5. And we've got all, in Pennsylvania now, we have all the private and the public payers, Medicaid and private payers paying for that. So you're following the evidence-based guidelines, and you're, helping oral health. So examples of things like that. We're hopeful that we're going to get postpartum depression screening paid across the board too. So thinking about, these pay for performance bonus payments. You might be getting bonus payments if your quality measures are high. And then also know that, as you have a high quality practice, that when your quality scores are higher with a payer, that helps them. The end game is that when they have better quality numbers, the payers are situated better. So that's why they push us so much. I mean, I'd like to believe that they all also really care about children's health, but they also have their own payment models where they get money from the government based on their own quality scores. So they want to engage with practices that have high pay-for-performance scores. So the idea is that, you get your scores up, you can sit at the table like Rocky Balboa and, I had to get that in there, and negotiate a little bit more because you've got, some scores that they're going to be after. And that's why you might hear stories. I mean, we're not really supposed to talk about our contracts, but if you ever may have heard that one of your colleagues with the same payer may be getting more money than you, they may have a Rocky Balboa in their office negotiating, or it might be that they have higher quality scores. So it definitely helps you with negotiating power when you excel. Because the payers need, I'm going to talk about HEDIS, it's my next slide, and to define it, because I think we use that term, and it dawned on me that, hey, does everyone even know what HEDIS is? And I wanted to take the time to define it. But payers need us. They need practices to do the work to improve these HEDIS scores. That helps them. So let me define for you what HEDIS is. So HEDIS it stands for Healthcare Effectiveness Data and Information Set. You guys have probably heard that phrase before, and one of the handouts that we have in your list there that Iris so graciously put together is the 2000, I think it's the ninth handout, it's a 2017 HEDIS at a glance with the pediatric measures on it. So it's a nice thing to print out. You could share with your, I think it's listed there as the last handout. So you have that there. So I think of, HEDIS as this retrospective review. So it's a look backwards at the year or the year prior. So it's a review of the services and the clinical care provided for your patients by you in your office. So I'm not going to go through the whole handout in the interest of time, but I wanted to just highlight this to you because I think HEDIS is important, and because it's a driver for the payers, I'll probably just highlight one or two, but this comes right from that handout.
Welcome back to this three-part series on quality improvement, presented on behalf of the PA chapter of the AAP and the PA Medical Home Initiative. The Pennsylvania Medical Home Initiative is a project of the Pennsylvania Department of Health in partnership with the Pennsylvania chapter of the American Academy of Pediatrics. This is meant to be an introduction and provide you with background information so you can effectively embark on quality improvement in your practice. Part 2 in our series will look at quality improvement and what's in it for you. Our learning objectives for this second segment are to identify the reasons to become involved in QI, to understand the ROI, or return on investment, for quality improvement participation, and to begin to envision what quality improvement can bring to your practice through your participation. You may be asking yourself why you should get involved in quality improvement activities in the first place. Some or all of these reasons may be relevant to you, but we will examine them in more detail individually. Caring for our patients is the core of everything we do. Sometimes our intentions are great, but our delivery and performance isn't as good as we know it can be. To start with, you can't improve what you don't measure. Many of us have the Lake Wobegon effect, where we think our performance is above average. But when we look at the real numbers, we come up shorter than we thought. This can be disheartening and overwhelming, but it doesn't have to be if we stay focused on our patients. We should work on improving care using evidence-based guidelines, like Bright Futures for well visits, and ACIP recommendations for vaccines. Patient safety should always be in the back of our minds when changing processes or working to improve. There's good data to show that patients and families who are engaged in their care are more likely to follow our recommendations and have better outcomes. One of our biggest challenges is to coordinate care with other parts of the larger healthcare system. And we must remember that our patients come with unique needs, and we should strive to meet them where they are and address their needs in a way that is relevant and accessible to their family. We touched briefly on the pay for performance in the previous presentation. Often additional dollars brought into the practice can help support the ongoing work of quality improvement and create a sustainable business model. For example, P4P bonus dollars might allow you to add a care coordinator or recall coordinator to help bring patients in to address gaps in care. Providing evidence-based services, such as well visits according to Bright Futures, adds additional patient visits to your practice. And in the case of well visits, it's without cost to the family. There are still practices across the state who have not started doing 30-month well visits or autism screening. Are you recalling patients with asthma or ADHD in accordance with clinical practice guidelines? Do you code and submit payment for review of Vanderbilt's and developmental screening or for fluoride varnish? Many of the private payers give P4P bonuses to practices because they have to report their plan performance on HEDIS measures to NCQA. How do they perform well? They need you to provide the services so that their numbers look good compared to their competition with other payers. They aren't seeing the patients, we are. They need us. There have been practices who use their high performance on quality measures to negotiate improved fee schedules for their own practice. The more covered lives you have of their insureds and the higher quality you can demonstrate, the more leverage you have for your practice. Not all of us meet the criteria to qualify for meaningful use or applied for NCQA patient-centered medical home recognition. But much of our healthcare system has some data submission requirements to meet regulatory mandates. Whether or not the programs on this slide apply to you, remember they are driving much of the change in how we all get paid, and pay for value means high quality at a reasonable cost. That high quality matters regardless of your personal regulatory reporting burden. Most practices that have undergone any degree of practice transformation using quality improvement as its framework and putting the patient at the center have reported improved practice satisfaction. Collaborating with other practices and sharing successes and strategies to tackle challenges makes us all know that we are not going this alone. Quality improvement requires teamwork, which we will explore more in part 3 of this series. You can't do QI alone sitting in front of your computer. It forces us to think across the practice more broadly, and often team members begin to see the bigger picture and their crucial role in the team. They understand their value in improving care for children and begin to think of ways they can contribute to solutions. The nursing staff in my office has much higher satisfaction as they've changed their thought process from, I need to give this immunization to this child, to, how can I help this child and their family today and make sure they are getting everything they need? Is this a young mom who is Spanish speaking and I can give her instructions on how to take a temperature and what to expect from the vaccines and how much Tylenol to give if there's a fever, so she feels comfortable and won't panic or go to the ER if the child gets a fever in the next 24 hours? Practices who involve family members as part of their team have universally seen the value in having that family perspective. We may think we know how the patient feels, what they need, what they want, but unless we actually ask and listen, we often have unmet expectations, and that results in suboptimal outcomes. For many of us, maintenance of certification feels like an additional burden. Regardless of your personal feelings, for now, it's what we have. The MOC Part 4 improvement in practice options are all focused on improving quality. The options have gotten more robust, and there is now the ability to create your own QI project and/or use your medical home recognition, which requires quality improvement, to meet this requirement. You can contact the ABP or the chapter for specific questions. So many of us have heard about the triple aim in healthcare: achieving better outcomes for patients and populations, lowering costs of care, or at least improving the value of what we do, and improving the patient experience. Recently, the fourth aim of improved clinician experience has been added. I believe that extends to all members of the healthcare team, from the front desk to the care coordinators, to the MAs, and to the physicians. When we put the patient and family at the center, and together we work to improve, we all go home feeling like we made a difference, and it improves our experience in delivering that care. This concludes the second in the 3-part series on quality improvement. We hope you agree that there is demonstrable return on investment for embarking on quality improvement in your practice and what you can hope to achieve through participation.
We are now moving into the third part of the QI series and really going through now what's involved, how are we going to roll up our sleeves and do this. So we want to kind of have the last leg here really focus on identifying what it's going to take for you to be successful. Also, I wanted to highlight the PDSA cycle of continuous quality improvement. And I also throw in a few things about, not to confuse you, but like some key diagrams and just some ideas for you guys to think about other things you can do. And start to envision what it will take for your practice to be successful. And, you know, again, this webinar is meant to be, you know, whetting your palate and gearing up for our big face-to-face meeting at the end of November where you can come with some of your practice teams. But we're hoping that this will, you know, help you begin to think about what you're going to do in your office next Tuesday. So we talked a little bit about quality, right? So quality is a way of thinking about our work. Quality is about achieving excellence, nothing less. And we think about, you know, the IOM definition of quality, and that's what we talked about earlier at the Institute of Medicine, where, you know, they're relating that quality piece to healthcare. So it's the degree to which healthcare services for our patients and our populations increase the likelihood of favorable outcomes, and they're consistent with evidence-based practice. So it really is taking that quality definition and putting it into our practice. And so when you think about success and setting your practice up for success, you always want to think about some of these 4 key principles. QI work really needs to look at systems and the processes, so looking at your office as a system and the workflow, and really thinking about how they work together. Focus on the patients and families. Focus on that team, that QI team, and make sure you have a family member or more that are partners with you. And using the data, that measurement, and having your data drive what you want to do. Focus on the lowest hanging fruit, or maybe the things that you need to make the biggest gains in. Because when you look at your quality report cards, you know, sometimes it actually, even though the lowest scores sometimes get you really sad, sometimes they're the easiest to make the biggest dent in. Sometimes it's a lot harder to go from 90 to 95% than it is to go from 50 to 70. So just think about that as you're embarking on this. You know, I think that about food a lot, so I had to throw in ingredients. And I think key ingredients in QI really include clinical knowledge and experience. So you want to think about your team looking at these basic QI concepts that we're touching on today and that we'll discuss more in November. And then again, this systems approach, so sort of an engineer kind of look at how your office flows everywhere from when the patient walks through the door to everything that happens after that they walk out the door in that bill and their whole experience within the office and follow-up. So, you know, Donna Bedian has this sort of framework. He talks about structure, process, and outcome. And so people kind of think about this. This comes from that HRSA Quality Toolbox. It's one of your handouts over here. So really thinking about, when you think about your office, sort of the structure and the input is really the patients and the staff that we have and the information and our technology. So it might be your electronic health record. It might be the vaccine. It might be the screener or the Edinburgh that you're doing. And then the processes are what it's done and how it's done. So what is your team doing? What's that patient experience like? What happens when they walk through the door? And then the outcomes are, how is that health care delivered? You know, did that child get that vaccine? Are they a healthier child? Is the parent walking out saying that their needs were met and that they're more satisfied with their care? And ultimately, does the child have a better quality of life or better outcomes? So I wanted, you know, there's multiple models, and I actually included slides on all of them. I think the Plan, Do, Study, Act is probably the ones folks are most familiar with. I actually decided to include the other ones in because I thought you may have heard these phrases, and I want you at least to be familiar with them if people talk about them. If you're someone that's kind of a quality nerd and you want to learn more about them, you certainly can go to conferences where you learn about these things. So Plan, Do, Study, Act, we'll show some exact diagrams of that. I think we've actually done PDSA cycles with those of you in medical homes, so for a lot of you this is not unfamiliar territory. The lean model that some people talk about is a whole pedagogy where it's based on time and cost efficiency and really driven by what the customer, in our place, you know, the patient wants. It comes from other, like the Toyota industry. And then Six Sigma, you probably have heard people talk and they'll say, you might see someone's like LinkedIn profile, I'm a Six Sigma black belt. So there's these, you go and get trained, and it's this, you know, it operates through these existing processes and new processes. It's a very sort of in-depth, kind of a certifying training that you go through. And And you may have heard of the Lean Six Sigma principles that actually Toyota and the Kaizen practices. That some of you may have heard of that. That's what sort of made them famous. So, you might say, well, we're not in the car industry. But again, just to think about that example I gave earlier with the airline, just thinking about what can we learn about customer service, because I think we need to focus on that. So I really like this slide. This is when we think about Plan, Do, Study, Act. And it's just this idea that, so when we're embarking on quality improvement, you're planning. So, what will happen if we try something different? So you're looking at that goal we talked about, thinking about what are our questions, when to carry it out, who's going to be able to do it, how are we going to do it, and where. So, you're thinking about how are we going to improve our HPV vaccine rates in our office. And so, then you have to sort of think about doing it. So how are you going to carry out that plan? How are we going to document any of the problems that we have? Are we going to, while we're doing it, are we going to, see any new ideas? So you sort of, you put your skin in the game, you jump in and you try it. You try, whatever your initiative. Maybe it's having the MA screen your charts. And then the study is really important. So you really want to think about studying it. So you got to look at, what happened before and after. What were our HPV vaccine rates before and after our intervention? Did we improve as much as we thought? We were trying to go to from 50% meeting the guidelines to 70. That was our goal, but we only got to 65. Why did that happen? And then summarize and make sure you talk to everyone in the group, because you want to get everyone engaged and people get excited when they can see progress. And then your act is, are you ready to implement the next cycle? Okay, we learned from this that one of the things that we didn't do was talk to the families in the waiting room, that we had this initiative and that we were going to be doing extra education on HPV. So our next cycle, we're going to embed that in. We're still going to focus on improving HPV vaccine rates, but we're going to engage our families better this time and do better waiting room education. And that was informed from your whole, your PDSA cycle. So that's just sort of a very, basic example, but I think walking you through these steps really helps. And I wanted to just take a deeper dive into this to kind of give you some guidelines if you're going to take some of this back to your office. So, you want to set some aims, so that goal, that planning, so you want to think about time-specific, measurable, and define the population. So you want to think, okay, we're going to do this HPV vaccine intervention for the next 6 months, and we're going to focus on girls and boys, and we're going to focus on the complete guidelines. We're going to start, at age 11, or maybe you might look at your data and say, hey, the older kids we've got, maybe we've really got to focus on kids 11 to 14 because that's our biggest gap. So you want to be very specific about your population and when you're going to do it. You want to establish your measures. So you want to very quantitatively define if there's going to be a specific change. So in the case of vaccines that I'm giving, it's a good example because the kid either got it or they didn't. You can use your records, your vaccine records. But sometimes you're doing quality improvement and you want to really, let's say you want to improve patient satisfaction, which is a little bit, more nebulous. You want to make sure you're using a validated tool or specific questions. And so thinking about how you're going to measure it and being very specific and quantitative so you can see your improvement is important. You want to select these changes. So all improvement requires change, but not all changes result in improvement. So you may have done something, changed the role, had a new medical assistant spend more time talking about the HPV vaccine before it was administered, but maybe it really didn't change that piece. You want to sort of think about what pieces, maybe if you're talking to your families, maybe families tell you, what the biggest barrier for us in getting the HPV vaccine is because we don't really understand what it is, and we think that, it's going to, talking about it with our youth is going to make them more inclined, to have sexual discussions or have, I'm just making some of this up, but just the idea that the parental perspective might be that they just haven't been given enough counseling and they have reservations, or we've talked about in my practice some of the reservations of some families of children that have very, very significant special health care needs against getting the HPV vaccine, but it's still a recommended practice guideline, and maybe we need to tweak how we're having that discussion and the importance of it. So you want to make changes in your office, but you really want to think about what can actually be moved. How are you going to move that needle? How are you going to implement that change? So you want to maybe try it on a small scale, but then refine it and maybe do several cycles. And then take it broad. Maybe you just want to roll something out with education with one medical assistant in your office, talking to families, see if it works, work out the kinks, and then go full court press and roll it out with all 6 MAs once you know this is what we're going to do. Sometimes it's easier to start small and then bring it to scale once you can say we know this is going to have an impact. It's important to think about sustainability. And we talk about that a lot in medical home, right? We always say you can't undo your medical home and your medical home principles. So I think it's really important to think about, after you implement this change, how are you going to make sure that you continue to have this HPV vaccine rate maintained, even though you've shown, an improvement? Are you going to implement and standardize and institutionalize the discussion that your MAs have with families? So, again, just to summarize, you want to identify your project aim. You want to develop that plan to achieve that aim. So think about who on your team, do you need to include in that initial rollout? What are their responsibilities? Do you need someone in billing to help you pull the immunization rates? You need a medical assistant who's going to be talking to the families. You need a physician champion. You may need an administrative person who can help administer the surveys in the waiting room. So think about the responsibilities. Think about what improvement you want to accomplish, and think about where you're pulling your data. Is it from your own vaccine records? Are you using payer data, the insurance company claims? Are you using Vaccines for Children data? And again, like anything, you want to establish timelines. You want to make sure that you enable enough time that you actually can see improvement. How many teams do we see in a typical 6-month period that would even be eligible for HPV vaccine? Maybe we need to do this over a year but have periodic meetings. So really think about identifying your outcomes, identifying, what data you need and how you're going to evaluate that data, how often to be looking at the data where you're going to see a meaningful improvement. That you're going to look at the data every month or every 2 months. You want to look at it at a time that can be inspiring and not deflating to your team. So that's sort of the PDSA approach. There's another approach that you may have heard of, is the lean approach, which is a management philosophy that's this idea of you're going to continuously eliminate the waste, and that you're respecting, by doing this, you're emulating your respect for people in society. So it really focuses on the value in the eyes of the customer or our patients and families. And you make flow value without interruption, so you're improving the flow and you're standardizing these work processes, and you're pursuing perfection. The whole idea in the training is that you never say, oh, we can't do this, we're never going to achieve this. You shoot for 100% and hope that you get somewhere close to that. And the culture is that you stop and you fix the problem as soon as it's identified. So it's this whole idea of the Toyota manufacturing culture. Something's wrong in the assembly line with the brakes, so you stop right then and there and you fix it. You address it. You don't wait till you make 10 more cars. So in our case, you have a VFC audit and you find that your HPV vaccines are low. So you stop right then and there and you pull a meeting together and you start with small steps of change. So the process in the lean model is you measure, you change, you measure, you change, so you keep going back until you keep getting the measurement result that you want. The Six Sigma, which is another approach, is the focus to what people say is eliminating the defects. So this whole idea of nonconformity of a product or service to its specifications. So they talk about how the processes have variation that results in very small, this parts per million defects. So you really want to really drill down, and that to the micro, to the individual patient and individual medical assistant. So you're looking at systematically this approach to reduce sources of variation and improve reliability. So you very much are looking at your patient satisfaction and your finances. You're very strategic. It uses a lot of project management concepts. So usually people that go through Six Sigma Lean training are often like office managers or higher level administrators. They do a lot of statistics. They talk about mistake-proofing processes so that the things can't go wrong. And so it's, you literally go through this black belt, sort of progression. So it's very rigorous. It's expensive, but, some folks will do things where they might have one person get trained, and then you can do like a train-the-trainer. So if you have multiple offices, or maybe you're in a hospital system, you get someone who's a Six Sigma Lean black belt, and then they might come in and share it with everyone else. One other terminology phrase that I wanted to throw out to the group was something called a root cause analysis. And the idea when you may have people heard grown up phrase. And the idea is that you're, I sometimes think I want to do a root cause analysis to figure out why one of my kids didn't unload the dishwasher, but I think you can do that. But I think that the whole idea about this, you could apply to anything really, is this process to look at the causal factors for variation in performance. So you're learning from the consequences. So, okay, wow, we looked at our rates of adolescent well visits and found that we went down by 20%. What could have possibly happened? And then maybe you dig deeper and you do the root cause and you're looking at these systems and processes. So maybe you run your report and see that, wow, of all of our no-shows last year, we had the highest percentages with adolescents. So the individual performance on this, a root cause is not a focus. It's not about blame. You're looking at your system. You're looking at ways to improve. I know that, for example, some of the Medicaid plans out where I am are we're talking about ways to improve adolescent well visits, so they're partnering with some of the practices to give adolescents gift cards when they attend the visits. So, the idea is that you look at root causes, you're drilling down to what could have been the etiology for what you're seeing and how you can fix it. In the hospitals, when we do this morbidity and mortality, when there's a patient fatality or a sentinel event investigation, this is the approach that they use, kind of looking at everyone who was involved, not about blame, but summarizing kind of the events so that we can learn from it and look at it from a systems way that we can improve the care. I wanted to just spend the last part of this third section, talk a little bit about some of the diagrams and things that you guys might use. Institute for Healthcare Improvement, we talk a lot about run charts. So we've done things, I know, in medical home where folks have been, for example, working on care plans. And so the idea of a run chart is that this is a visual depiction looking at, let's say your practice is going to start working on making sure that every child with a complex need got a care plan. So the idea is that you're measuring this over time. You look at your baseline data, and then you graph out, okay, the process change one was that we incorporated this into our EHR, and you put, you remember the time that you did that, and then you continue to track the data, and then you look at maybe what a second intervention is that maybe that process change two. So at this time, we had our parent partner talk to parents about the importance of care plans. And then maybe process change three for care plans was we had the care plans available on our patient portal. So families were now beginning to ask for them, and our providers were getting more interested in completing them. And the idea of a run chart is that you look over time and whatever you're measuring, in this case, the example I use was care plans, and it allows you to see your improvement. And so you say, wow, maybe it looks like we had the most bang for our buck for that first process change measure. And look, at this process change measure, we really didn't change any of our outcomes. So it allows you to drill down visually and pictorially a way to see what the impact was of some of the interventions that you did. And that's, again, the value of data and measurement. Some other folks, and I don't want to get too into the weeds of this, and I know I've been throwing a lot of information out at you, and we'll talk more about this at the conference, but I want you to certainly have this diagram. And one of the things that the Institute for Healthcare Improvement talks about is something called a key driver diagram. And this is a template that we provided for here, too. And you can use this as an approach. It depends, again, on your management style or the way you think. So you might have an aim, so thinking about, our aim is to improve, I'm just going to try to think of some of the HEDIS measures, lead screening. So we want to have at least one capillary venous lead test by the second birthday because our numbers were down. Well, what are some of the drivers for that? So some of the drivers might be, families coming to appointments, families' insurance, whether they can get their labs drawn on site, how far away the closest place it is to get a lab, families' compliance or losing the lab slip. So you kind of want to go through the primary drivers that would be affecting your outcome and then the secondary ones. And then that last column is like the change ideas. So maybe it's that, you have a lot of patients in your practice that have a certain insurance that can only use LabCorp, and the closest LabCorp is, blocks away. So maybe you talk to the plan, or maybe you figure out, can LabCorp come on site? Would they have an opportunity to draw labs in your office? Can you do your own lab draws? Maybe families are losing the lab slips. Can you make those lab slips available on your patient portal? So if families lose it, they can go on and download it without having to come back. So you kind of want to, this kind of walks you through a template. And I think key driver diagrams are really helpful, like in team meetings. So the idea is, I think the value is sitting down, not with one person, but a team, sort of thinking about what are we trying to accomplish, what could be affecting it, and really getting the input of the people on the ground to think about how we can change it. So thinking about this templates and what we included in your slides, are some examples. So this framework helps us clarify our improvement goals, and so, we talked about the drivers, it's the key areas of research. The secondary drivers are actions we can take to implement, and then the change ideas are things that we can do to help us implement those drivers, as I said. So I included in here just, examples of some filled out where you can look at the ones that I found in one of the pediatrics articles was, CTs for children less than 21. Kids were getting them, if they only had minor head trauma, they shouldn't necessarily be getting those CAT scans, and kind of thinking about why might they be getting them, and why, what can we do? And so thinking about who's affecting that. So it might be the evidence, the clinician who's seeing them, the parents, and the awareness. So, and then thinking about how you might roll that out and education. So just wanted you to have a couple of key driver diagrams in your slides to kind of walk through. I wanted to talk a bit about, I think I've touched on this, but I think it can never be overemphasized in this whole idea of being very patient-focused. So, we have to always remember that the extent to which we meet patients' needs and expectations, is important. And you can't just think about the patients who are in front of you. Sometimes I worry most about the kids who have not come in and have these gaps in care. So that's why you want to think about population management and really look at those lists of patients that you have from your payers, the ones who are coming in, but the ones that aren't, and identifying what are those barriers and having someone on your QI team address those lists of the care gaps and thinking about maybe key diagrams on some of those care gaps. And again, I think if you involve your patient and family representatives to say, hey, why aren't our adolescents coming in? Why aren't you getting your adolescents in for their checkups? What are some of the barriers? Maybe it's the hours of your office, but hey, somebody you there say, hey, your card really helps them, I do come, that kind of thing. One of the handouts that we have on our files there for you is a great policy statement that came out from the American Academy of Pediatrics just last month on the guiding principles for team-based pediatric care. It really underscores a lot of what we talk about in medical home, and I think a lot of you are also already teed up. You guys have a medical home practice teams. And so really thinking about being part of that team, we wanted you to have the policy statement and continuing what you're doing. I think this is old hat. I think you guys got this. But I think when you think about QI, think about your team and who's working on that. Or, whether you're doing it in the context of who's the best person to be pulling the data and talking to the payers, who's the best person that has a perspective on what actually happens in the flow and how patients are brought back. Each person has their skill set and adds to the ideas. And so you really want to think about keeping the patient and the family at the center and really thinking about that policy statement, because I think it's a good one. It's a great one to review, and you have that as part of your toolkit from us today. Dr. Kressly is going to talk a little bit in our last video about that data and how the information is power. So I think all of us, I know for us, like years ago when we started on transition, one of the things we did was, me and at the time Dr. Nesby, who were the only two physicians here, we were thinking about transition and embarking with medical home and doing more transition, and we sort of had a prediction, an over-under, like Price is Right bet on how many youth we had that were over 21, and we egregiously underestimated it. The power of the data giving us that information from our practice management system was humbling, and it really was a kick in the pants for us to develop a transition program. So thinking about that data to get you motivated, thinking about that baseline, so let's say you want to run a run chart like I showed you, or just knowing what your delta is, it also just helps you to monitor if you made a difference. Did that intervention help? Did what we do, actually lead to an improvement? And it also helps you look at, hey, maybe at my one office in this site, we seem to be doing great with our lead screening, but over here we're not. What are the differences between the two offices? Is it staff? Is it location? Is it where the lab core is? Or the quest? So you really want to have that data. You want to look at the qualitative data. So that may be some of the things we talked about in terms of provider satisfaction or patient satisfaction.
Welcome back to this three-part series on quality improvement presented on behalf of the PA chapter of the AAP and the Pennsylvania Medical Home Initiative. The Pennsylvania Medical Home Initiative is a project of the Pennsylvania Department of Health in partnership with the Pennsylvania chapter of the American Academy of Pediatrics. This is meant to be an introduction and provide you with background information so you can effectively embark on quality improvement in your practice. Part 3 and the final in our series will look at what's involved in quality improvement. Our learning objectives for this third segment are to identify what it takes to be successful at quality improvement, to understand the PDSA cycle of continuous quality improvement, and to envision what it will take to be successful in your practice. Quality improvement that is successful incorporates attention to people, processes, and technology. Key principles include systems and processes, keeping the patient and family at the center, reinforcing the team it takes to do the work, and focusing on the wise use of the data. This is a great schemata from the HRSA Quality Toolbox. That's HRSA. I encourage you to explore the tools and information that are available on their website. There has been thoughtful study of what it actually takes to improve and sustain quality, and you should not reinvent the wheel in your practice. Take advantage of tools in the public domain to educate yourself and your QI leaders in your practice. The inputs to the process are outlined above, and almost all QI projects involve the people, the infrastructure you have in place, materials, be they patient education materials, vaccines, etc., and the technology. The processes you put in place or the activities of your team include not only what's done, but how it's done. Together, the resources and the activities are what drive your results. Most of you should be familiar with this plan, do, study, act of the PDSA cycle of quality improvement. True QI cannot be accomplished without all 4 phases of this process. Planning without acting rarely results in improvement. I always plan to exercise to lose weight, but somehow when I don't find the time to make it happen, I shouldn't be surprised there's no improvement. If you have your plan translate to action, you really need to study what happens. If you're not looping back to assess the effects of what you've done, you may have a false sense of improvement or may have made things worse. I want to bring your attention to the act portion of this cycle. Notice that the default isn't always to widely adopt the plan you began with. Most times there are needs to adjust your original plan as you gain more information, or sometimes there's unintended consequences. This should be an iterative process and not one trip around the circle. I cannot stress enough the willingness to abandon a plan that simply isn't working the way you expected. This is very difficult to do when you've invested a large amount of time and energy. However, sometimes the timing isn't right, sometimes you need different perspectives, sometimes you don't have the right technology and you need to regroup. Sometimes additional training is needed. It's okay to abandon a plan that is not having the desired outcomes. You didn't fail. In many cases, you learned something very valuable that you can incorporate later. An example in my practice of a project which didn't work out as planned was our ADHD follow-up project. Doctors noticed we were refilling ADD meds for patients who hadn't been seen in a while, for our colleagues who were not in the office that day for one reason or another. Sometimes meds were being refilled for patients who hadn't been in over 6 months. Sometimes we would refuse to refill the prescription until they made a follow-up appointment. But the doctor who usually saw them felt like they were stable and didn't need to be seen every 3 months. We started a project where the person who saw the patient would write a task in the electronic health record for the appropriate follow-up visit. But this fell apart when doctors forgot to do it, or parents said they would call back when they had their calendar in front of them. In addition, the report which we could get out of the EHR didn't really reflect what we were trying to accomplish. And there wasn't actually agreement among the doctors on how often to see the patients back. We abandoned the project. We're going to regroup this fall using some care plan functionality in our EHR and start first with a discussion about who should be seen and when and how often. In the meantime, we've incorporated electronic prescribing of controlled substances in our workflow, and we're trying to figure out how to document checking the state controlled substance database as part of that process. Stay tuned for how this plays out. Many practices get in the habit of doing things in a certain way because they always have. If you are truly going to improve quality, you need to carefully reflect on your ability to meet your patients' needs and their expectations. You may be doing a great job of not giving antibiotics for URIs, but if your parents expect to leave with a prescription, they may not have a satisfactory experience. Do you then need an educational campaign on the appropriate use of antibiotics for your patients? What would that look like in your practice? Gone are the days when you can just take care of the patients who show up at your office for care. You should also be proactively reaching out to all of the patients who are attributable to your practice and get them in to receive appropriate services. There are certainly challenges in trying to find differences in what you think your active patient list is and what the payers do, but you must start with having a process to maintain your active patient lists so you're internally consistent. Involving patients and families in the process can be eye-opening. In my practice, we were going to add more evening physicals, but our mothers with young children told us that they would prefer early AM appointments and just drop their kids off at daycare a bit late and then head to work, rather than trying to reverse engineer the end of their workday with a cranky toddler in their car. Okay, it's time to admit that we can't individually do this work. We need to make teams that include all roles in our office. We also need to empower those teams to speak up, problem solve, and give our team members training and education to execute our plans. As practice leaders, we can decide that all missed appointments need to be followed up on and develop a protocol. But if we aren't actually doing that work, we need to listen to the folks who are doing it and get their input if we're going to succeed. We also need to understand that all patients don't need the same comprehensive team. Some patients' effective team members may not even work in our practice, like a social worker or a school nurse or a teacher for a particular patient. I encourage everyone to read the new team-based care policy statement from the National American Academy of Pediatrics. Data really is the key to practice empowerment. Having a way to see measured performance can be eye-opening. Most practices say, "This can't be my data." We tend to have a positive reflective memory and selectively forget the times where we made an exception or something didn't happen the way we knew it should. For example, our practice really thought we were good at writing generic medications for ADD. Then we ran the report. The report gave us actionable data. We could check the patients, see what each of us wrote, and lo and behold, we were writing more name brands than we thought. Why does this matter? In many cases, it's both a higher cost for the family, and most people have tiered copays based on formulary or generic prescribing, and the payer has a higher cost. You may think that that doesn't matter to us, but it should. Payers are painting profiles regarding the total cost of care. And in the eastern part of the state, we're actually getting bonus pay for performance dollars for keeping down the total cost of care and for generic prescribing. Two different buckets of money we can gain if we're good at this. Once you have a baseline, and you can do a root cause analysis to identify where and why gaps in performance happened, then you can develop your plan to improve and prioritize it. You can also then compare different office sites, your colleagues, provider to provider, use the information to work collaboratively to raise everyone's performance. Once you're a rock star, you have to make sure you don't slip and continue to monitor your data. Make sure you adopt, adjust, or abandon as needed. There is value in collecting feedback to see how you are doing. This can be a rating survey or simply comments. I encourage folks to not only measure qualitatively how you are doing with your patients, but also your practice team. Where do they see additional room for improvement? Are they struggling to make the plan work? Do they have a suggestion? It's also very helpful to sometimes be an observer. Be a fly on the wall. Follow a patient from your front desk to the exam room and back out. Did you deliver the way you strove to? Is there room for improvement? Don't use that information in a punitive way, but in a way that you can continue to improve. For data to be as valuable as possible, it needs to be clear and actionable. For every metric you submit information or query you run, you should know exactly what the numerators and denominators are. If you're trying to determine what percentage of your active patients had a well visit in the calendar year, how is active patient defined? Is it any patient who has an active status flag on the patient register? Is it any patient who has been seen at least once in the past 3 years? You also need to harmonize what you think is the right way to define the denominator and how the information is actually getting pulled from your EHR or practice management system or from the payer. What does it mean calendar year? Is it starting from today and looking back 365 days? The payer's likely defining it as any time from January 1 of the calendar year to December 31st of that same calendar year. Can your system replicate the query the payer's using? In most cases, the payer is getting everything from claims data, and you have more accurate information in your system. However, you need to negotiate with the payer an opportunity to provide additional information. Great example. For QI measures involving vaccination rates, what do you do with families that refuse specific vaccines? Will the payer allow you to submit additional supportive information, such as an AAP standard vaccine refusal form with a signature, in order to have those patients be included in their numerator? Someone should understand the data mapping in your system so you know where information is being pulled from in various reports. For example, if you're doing a QI project to improve follow-up on newborn screens, where's the query coming from? If you have the result in a scanned record, but it doesn't have the correct label, the computer may not count that scanned record. Many times scanned documents can't be counted in an electronic query because it's really just a picture, which a computer can't read. Do you also need to check a box or put an entry in a discrete data field for newborn screen reviewed in order for it to be counted? If so, who's going to be responsible for doing that? Actionable data is key. If you can identify with that query the patients that didn't get services, then go look at their charts and find out why. Did they no-show for an appointment and no one ever contacted them to reschedule? Are they really not active patients and moved 6 months ago? In order to begin to figure out how to improve, you need a clear understanding of why your baseline performance is what it is. In order to lead, you need to feel a common mission. Does your practice have a vision or mission statement? Is it shared by the entire practice? We know that our patients perform best if there is clear expectation setting and continual reinforcement. No setting is more difficult to improve than when not all the leaders are on the same page. How is the rest of the team supposed to know what to do if one doctor is recommending HPV vaccine at age 11 routinely, and another is telling parents it's okay to wait until high school? Some providers may need training on how to manage conflict and on shared decision-making with families. Some team members may need new skills. Empower everyone to work to their fullest potential, to speak freely when they are identifying barriers, and to work collaboratively with others to problem solve. A great leader makes sure all of this happens and works to make sure that communication not only happens, but it's effective. Posting notices that say, from now on, everyone must offer HPV vaccines at age 11 or get a refusal form signed, is not really likely to actually improve your HPV immunization rates in your practice. When you embark on quality improvement, it's essential that your entire practice team is bought in and brought along. If you have reluctant team members, identify their obstacles and work to overcome them. If they refuse to be part of a particular project, consider getting them on board something that they can feel good about. Everyone that is a key stakeholder in the improvement process must have a clear understanding of why you are doing it and believe in the project plan. It's not enough to have a kickoff meeting and get everyone psyched. You actually have to monitor that the buy-in is sustained and find ways along the way to support it. Consider setting short-term goals and having a practice ice cream party to celebrate your mini goals when you achieve them. Set yourself up for success. Especially in the beginning, set small goals that are realistically attainable so the team can feel good about their work. This slide says it all. We are always a work in progress. There is always something more we can do or another project to improve. But celebrate those small successes. Don't talk about failure. Talk about barriers to success. What got in the way, why, and how can we learn from it? Even if you get to what you think is the highest possible goal, keep monitoring it and be mindful of thanking folks for the work that they are doing to sustain the achievement. Now that you're getting excited about QI, remember that doing too much at one time is exhausting and can even result in compromise in patient safety. Change should be paced, manageable, and it's okay to take a breather for a while if you have done some great work. Encourage team members to think outside the box. Some of your youngest or newest staff may have some of the best ideas. Some of it may come from when they trained, and they were thinking to themselves, why in the world do they do it this way? Encourage everyone to suggest ideas for QI projects. If the front desk thinks there has to be a better way to deal with getting HIPAA consents, let them suggest a project and brainstorm the solutions. They have to do the work, and if they are more efficient, they have an extra moment to smile at the parent and notice that the sibling has an outstanding balance on their account. Everyone can win when the entire team has a continuous improvement mindset. This concludes the third and final in the three-part series on quality improvement. We're excited that you have come on this journey with us to understand what is needed to create a successful quality improvement program in your office. We hope you're ready to begin to plan what projects you might want to embark on and who you will need to be on your QI team. Thank you so much for your time and attention. It's been my pleasure to host this three-part series on quality improvement for your practice. And at any time that I can help you embark upon the journey, please feel free to reach out to me.